Hey, yo, welcome back to Book Podcaster. Let's be real. Sometimes life feels like you're wading through mental fog, right? Especially if you're juggling studies, maybe work, all the other stuff going on. It can get overwhelming.
Yeah, definitely. That feeling is pretty common.
So today, we're doing a deep dive into something that's, more than just an off day or feeling blue. We're talking about depressive disorders.
Exactly. And it's not just one thing, it's complex.
Right. Our goal is really to break it down, make it clear, supportive. We're drawing from expert definitions, real-life examples, too.
Think of it like having a knowledgeable friend just walk you through it all. We want to cut through some of that complexity for you.
Okay, so where do we start? The definition, maybe.
Sounds good. So, clinically, drawing from our source, Townsend, we're looking at mood disorders. The core is this really pervasive sadness.
Pervasive, so like it sticks around.
Exactly. It's persistent. And crucially, there's also anhedonia.
Anhedonia. That's the term for losing interest, right?
Yeah.
In things you actually used to enjoy.
Precisely. Plus, you often see changes in sleep, maybe appetite changes too, and these really heavy feelings of worthlessness or sometimes even suicidal thoughts.
That sounds intense. It's not just having a bad week.
No, not at all. And seeing how it plays out helps. Take the example of Derek, the teacher, 42 years old. He loved the chess club, mentoring, but then he just pulled back, lost interest,
Okay.
stopped eating properly, lost weight without trying, felt like a burden. And the key thing, this went on for months.
Months? Wow.
That duration, that level of impairment, that's what points towards something like major depressive disorder or MDD. It really impacts his whole life.
Right. And you mentioned MDD, which brings us to the point that depressive disorder is sort of an umbrella term, isn't it? There are different types.
Yes, absolutely. It's not one size fits all. MDD is the one we often hear about most, that persistent sadness or loss of interest for at least 2 weeks, significantly impairing function, like with Derek.
Okay. What else falls under that umbrella?
Well, there's persistent depressive disorder, which used to be called dysthymia.
Dysthymia.
Yeah.
Right.
Think of it as a chronic sort of lower grade depression. It lasts for at least 2 years, sometimes longer. It might not be as severe day-to-day as MDD, but it's this constant weight.
Like a constant background hum of feeling down.
That's a good way to put it. It really dampens mood and energy long term.
Okay. And hormones can play a role too, right? Like with PMDD.
Definitely. Premenstrual dysphoric disorder. This isn't just typical PMS.
No.
No. We have an example, Jenny. For her, it's intense mood swings, serious irritability, anxiety, all specifically hitting in that premenstrual phase. It's much more severe and disruptive than PMS.
Gotcha. So very cycle specific.
Exactly. Then you have depression linked to substances or medications.
Ah, right. Like alcohol or certain drugs.
Yes. Substance or medication-induced depressive disorder. Think about Mark in our source material. His mood tanks whenever he binge drinks. We have to remember alcohol is a depressant.
The central nervous system depressant, yeah. So it makes sense it could worsen or trigger depression.
It absolutely can. And certain prescribed medications can sometimes have depressive symptoms as a side effect too.
And the last type mentioned?
That would be depressive disorder due to another medical condition.
Okay, so like a physical illness causing depression.
Precisely. Things like having a stroke or Parkinson's disease, hypothyroidism. These conditions can directly trigger depressive symptoms. It really shows that mind-body connection.
It does. So recognizing these different types is super important for getting the right help.
Couldn't agree more. Diagnosis drives treatment. Understanding the specific type helps tailor the approach.
Okay, so we know what it is and the different forms it can take. But why? What's going on underneath? The etiology.
The why. It's usually not just one single cause, It's often a mix of biological and psychosocial factors.
Okay, let's start with the biological side. Neurotransmitters come up a lot.
They do. The theory is that deficits or imbalances in key neurotransmitters, think serotonin, norepinephrine, dopamine, play a big role. These are like the brain's chemical messengers for mood.
So if the messengers aren't working right, the mood gets affected, like a communication breakdown.
Sort of, yeah. The signals aren't getting through properly. Then there's neuroendocrine dysfunction.
Okay.
Specifically, the HPA axis, hypothalamic pituitary adrenal axis. That's your body's main stress response system.
Right. Fight or flight.
Exactly. In depression, the system can become hyperactive, like the stress alarm is constantly on, even when there's no immediate threat. That contributes to anxiety and feeling overwhelmed.
Wow. And genetics. Does it run in families?
It can.
Yeah.
There's definitely a genetic predisposition. If you have a family history of depression, your risk might be somewhat higher. It doesn't guarantee it, but it's a factor.
Okay, so biology plays a part. What about the psychosocial side, the psychological and social stuff?
Yeah, equally important. One concept is learned helplessness. Seligman studied this.
Learned helplessness.
Imagine being in situations repeatedly where nothing you do seems to change a negative outcome. Eventually, you might just stop trying. You learn to feel helpless even if later you do have control.
That feeling of being trapped, like nothing matters. I can see how that leads to feeling down.
Absolutely. Then there's Beck's negative cognitive triad.
The triad, right? Negative views of.
Yourself, the world, and the future. So thoughts like, I'm worthless, everything always goes wrong, and it's never going to get better.
Like looking through really dark glasses all the time.
Exactly. Our source mentions Sophia. She blames herself for everything, feels totally hopeless, sees the world as unfair. That's the triad in action. It's a powerful pattern of negative thinking.
It sounds like an inner critic just running wild.
So that's a good analogy. And finally, we can't overlook early experiences. Things like childhood trauma or significant loss can leave deep emotional scars and increase vulnerability to depression later on.
Makes sense. Okay, so causes are complex, often a mix of things. Now, how do we recognize it? What are the actual symptoms we should look for?
This is where that mnemonic SIGCAPS comes in really handy for remembering the core symptoms. It's widely used.
SIGCAPS. Okay, let's break it down. S.
S is for sleep disturbance. Could be insomnia, not being able to sleep, or hypersomnia, sleeping way too much.
Okay.
Interest diminished. That's the anhedonia we talked about. Losing pleasure or interest in activities you used to enjoy.
Ye.
Guilt. Feelings of worthlessness or excessive, inappropriate guilt.
Ye.
Energy loss. Feeling fatigued, tired all the time, no matter how much you sleep. Concentration issues. Trouble focusing, remembering things, making decisions. Indecisiveness is common.
Yay.
Appetite changes. Significant weight loss when not dieting, or weight gain. Or just a marked change in appetite, up or down. Psychomotor changes. This can be agitation, restlessness, pacing, fidgeting, or retardation, which is a noticeable slowing down of thought, speech, and movement.
Okay, interesting. And the final S?
Suicidal ideation. Thoughts of death, dying, or harming oneself. This is always the most critical symptom to
The
assess.
sleep matters. Sleep, interest, guilt, energy, concentration, appetite, psychomotor, suicidal ideation. That's really helpful.
It is. Think about Mrs. Ray from our source. She stopped gardening loss of interest, the I. She had insomnia, sleep disturbance, S. And she expressed feeling worthless, like a burden that's the G.
Right, putting it together with an example makes it clearer.
Exactly. And remember, someone doesn't need to have all of these, and the intensity varies. But a cluster of these symptoms lasting for at least 2 weeks is a red flag.
Okay, so if someone is experiencing these things, what helps? Let's talk treatment.
Broadly, there are 2 main avenues: medications, which is pharmacological treatment, and therapies like talk therapy, which are non-pharmacological. Often, a combination is most effective.
Makes sense. Let's start with meds. Antidepressants.
Right. There are several classes. They generally work by trying to rebalance those neurotransmitters we discussed earlier: serotonin, norepinephrine, dopamine.
Okay. The source mentions SSRIs first, like fluoxetine, sertraline.
Yep, selective serotonin reuptake inhibitors. They primarily target serotonin, often first line because they tend to have fewer side effects than older meds.
Okay. Then SNRIs, venlafaxine, duloxetine.
Serotonin norepinephrine reuptake inhibitors, they work on both serotonin and norepinephrine, can be particularly helpful if someone also has chronic pain issues alongside depression.
Got it. What about the older ones, TCAs and MAOIs?
Tricyclic antidepressants, like amitriptyline. They're effective, but can have more side effects, like dry mouth, constipation, blurred vision. Those are called anticholinergic effects. They need more caution, especially in older adults.
Right. And MAOIs.
Phenelzine, monoamine oxidase inhibitors, also effective, but they come with significant dietary restrictions. You have to avoid foods high in tyramine-aged cheeses, cured meats, some wines.
Why that?
Because mixing tyramine with MAOIs can cause a hypertensive crisis, a dangerously sharp rise in blood pressure. So strict adherence to diet is crucial.
Wow, okay, that's serious. Any others?
There are atypical antidepressants too. Bupropion is one. It has less risk of sexual side effects, which is good, but it can lower the seizure threshold, so it's not for everyone. Mirtazapine is another. It can be quite sedating, so it's sometimes used when sleep is a major issue.
Okay, lots of options, but they all need careful consideration. And there was a really important safety warning mentioned too.
Yes, absolutely critical. The FDA black box warning.
For all antidepressants.
For all of them, yes. There's an increased risk of suicidal thoughts and behaviors, particularly in adolescents and young adults, especially when first starting the medication or changing the dose.
So close monitoring is essential during that initial phase.
Absolutely vital. Patients, families, and clinicians need to be vigilant about any changes in mood or behavior.
Okay, so that's the medication side. What about non-pharmacological approaches? Therapy.
Yes. Talk therapies can be incredibly effective. Cognitive behavioral therapy, or CBT, is very common.
CDT. That's about changing thought patterns.
Exactly. It helps you identify those negative thought patterns like the cognitive triad we talked about, challenge them, and replace them with more realistic, healthier ways of thinking and coping.
Okay. What else?
Interpersonal therapy, or IPT. This one focuses more on your relationships and social roles, how you interact with others, dealing with grief, disputes, or big life changes like retirement or a move.
So more focus on the social context.
Right. And for very severe or treatment-resistant depression, there's electroconvulsive therapy, or ECT.
ECT, that sounds intense.
It can seem that way, partly due to media portrayals, but it's a safe procedure done under anesthesia, and it can be incredibly effective, even life-saving, when other treatments haven't worked. Our source mentioned Marina, who had a significant improvement with ECT after meds failed.
Okay. Good to know. It's a real option for some. Any others?
There's also transcranial magnetic stimulation, TMS. It's non-invasive, uses magnetic pulses to stimulate specific brain areas involved in mood.
Interesting.
And we shouldn't forget adjunctive therapies, things like regular exercise, good sleep hygiene routines, mindfulness practices.
These aren't maybe the main treatment, but they help.
Definitely. They are evidence-based ways to support overall well-being and can really complement medication or therapy. Think of them as boosting your mental health toolkit.
Yeah, like building resilience. Okay, now, the source also gets into the nursing perspective. Key things for healthcare folks, or even just friends and family to keep in mind.
Super important. Number one is always suicide risk assessment.
Asking directly.
Yes, asking clear, direct questions like, are you having thoughts of hurting yourself? Or, have you thought about ending your life? It doesn't put the idea in their head. It opens the door for them to talk about it if they are struggling.
And if the answer is yes, or even maybe.
Then immediate safety measures are crucial. Removing access to potential means of self-harm, ensuring the person isn't left alone if the risk is high. Safety first.
Always. What else from a care perspective?
Well, appetite is often poor, right? So instead of big meals, offer small, frequent, nutrient-dense snacks or meals, easier to manage.
Okay, practical tip. And sleep.
Promote good sleep hygiene. Encourage a regular sleep schedule, a calm bedtime routine, limiting caffeine, especially later in the day.
Makes sense. What about just basic functioning? Getting dressed, showering?
Activities of daily living, ADLs. They can feel monumental when someone's deeply depressed. Gentle encouragement and assistance, breaking tasks down into small steps, can help maintain dignity and routine. Don't push too hard, but offer support.
And communication. What helps and what really doesn't help?
What doesn't help are platitudes. Things like, just cheer up, snap out of it, look on the bright side. They invalidate the person's real pain.
Yeah, I can see how that would feel dismissive.
Exactly. What does help is therapeutic presence. Just being there, listening without judgment, showing empathy.
So less talking, more listening.
Often, yes. And using validating statements, like the example, it sounds like things feel really heavy for you right now. I'm here to support you. Acknowledging their struggle without trying to fix it instantly.
That feels much more supportive. Showing you're there with them in it.
Precisely. That connection can make a huge difference.
Okay. To kind of pull this all together, the source gives a case study, right? Mr. Thompson.
Yes, Mr. Thompson.
Sure.
A 58-year-old widower. He was experiencing fatigue, insomnia, loss of interest, classic signs.
SIGCAP symptoms.
Definitely. He denied suicidal thoughts but was crying daily. So he started on sertraline, an SSRI.
Okay, medication.
And also weekly CBT sessions.
Therapy, so a combined approach.
Exactly. And over time, he started improving. He got back into his gardening, reconnected with friends, even started volunteering.
That's great.
It really shows how treatment works. It addressed the biological side with meds and the thinking and behavioral patterns with therapy, leading to functional recovery, a return to activities he valued.
That's a really hopeful story. It shows that recovery is possible.
Absolutely. It takes time and the right support, but improvement is definitely achievable.
So wrapping things up then, what's the main thing you want people to take away from our deep dive today?
I think the biggest takeaway is that depression is It's complex, yes, but it's also understandable and treatable. Knowing there are different types, understanding some of the potential causes, recognizing the symptoms with things like SITCH-CAP-S, it all helps demystify it.
Right. It's more than just sadness.
So much more. And knowing effective treatments exist, both meds and therapy, is crucial. Understanding these things is really the first step through that fog.
Yeah. And if you're listening and feeling like you're stuck in that fog, like you're trying to figure out those impossible instructions, remember, it's okay to take it one step at a time. Seriously. And reaching out, whether it's to a friend, family, or a professional, that's not weakness. That is strength.
Absolutely.
You've got this.
Yeah.
And there is support out there when you need it.
Yeah.
Yeah. Be kind to yourselves.